Good evening. We're broadcasting from the unceded and unsurrendered territory of the Algonquin Anishinaabe. I'm so thrilled to welcome you all to the Writers' Festival's 2021 virtual season. My name is Sean Wilson. On behalf of the festival and the Ottawa Public Library, it gives me great pleasure to welcome you all to tonight's event on the urgent need to improve the lives of Canada's elders. As always, I want to thank you for supporting authors and booksellers through these difficult times. Our official bookseller is Perfect Books on Elgin Street, and I know that wherever you are right now, there's an independent bookseller nearby who would be more than happy to sell you some great books. And the Ottawa Public Library is fully stocked and ready to serve your reading needs as well. Our spring season continues into June, and it's all available online, free and on demand at writersfestival.org. And all you need to do to connect with some of the world's most acclaimed authors is click play. If you enjoy this event or any of our virtual programming, please consider making a charitable donation. Your financial support will allow us to continue to bring you the world's most interesting authors and thinkers. Now, let's turn it over to our host, Elizabeth Payne, whose excellent work at the Ottawa Citizen has long included the Health Beat, and we're in great hands. Let's give a warm virtual welcome to our host, the Ottawa Citizen's Elizabeth Payne.
Thank you very much, Sean. I'm really pleased to be here tonight to welcome André Picard, author of Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. So let me introduce André, and then we're going to get down to a discussion about the last year and more of this pandemic and elder care in this country. So André is a health reporter and columnist with the Globe and Mail and one of the most authoritative voices on healthcare in Canada. He's the author of 5 best-selling books, I think it's 5, and a 9-time nominee for the National Newspaper Awards, Canada's most prestigious journalism awards, and his latest nomination came just last week. So congratulations, André. He is also an Energizer bunny. In addition to covering this unprecedented pandemic and writing the book we're discussing today about the elder care crisis in the wake of the pandemic, he is frequently heard on TV and radio, and I think has just finished a panel discussion minutes ago. So he's also a bit of an anomaly in Canada, celebrity journalist of sorts, and that is a rare thing I can attest to. I've been to conferences and seen people bypass keynote speakers to line up for a chat with André. So I'm very pleased to be able to welcome André Picard virtually to the Ottawa International Writers' Festival this evening to talk about his timely new book, Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. Welcome, André.
Thank you. Thanks for that very kind introduction. I feel like I should do a long introduction of your stellar career as well.
Oh. we could go back and forth. Yeah. Well, let's start at where we are now. We are more than a year into this pandemic, and for everyone, I think it's probably going to take a really long time until we can even begin to digest what we're going through. But we're more than a year into it now. We're headed into a third wave. And what has this been like for the elderly in care in Canada?
I think there's no question that no demographic group has been hit harder, especially people in institutional care. So we've had roughly 22,500 deaths in Canada from COVID, and more than 16,000 of those have been elders in long-term care. And more than 90% of all the deaths have been people over the age of 65. So a mix of in and out of the community. So this has really been devastating to elders in this country and around the world, but particularly so in Canada. We have one of the worst records proportionally of our older citizens being impacted.
Yeah, and I would like to talk about that later too. When I read this book, I have to say I could hear the frustration and anger in your voice. Tell me where that came from.
Well, I think just from writing about these issues for years and years and just seeing what happened during the pandemic, bringing everybody's worst fears to bear was just frustrating. Knowing that all this stuff existed before, it could have been corrected. Just knowing, I think anyone with the slightest knowledge of how the system operates, how long-term care homes look, knew that this was going to be a disaster from day one. We saw it happening in Italy and Spain weeks before the virus even came to Canada, and yet we did nothing. You know, we have a premier in Ontario who talks about an iron ring. Well, there wasn't even a paper ring put around these homes. They were just left to fend for themselves for weeks. And by that time, there were literally thousands of dead before we started taking this seriously.
In the fall, I think the early fall of 2019, really just months before the pandemic, and I think the more we know about it, we know now there were probably already cases in parts of China in the fall, but there was an international panel warning that a deadly global pandemic was coming and we weren't prepared. I think that was one of just many over those years, correct? I'm just wondering, can you go back to the beginning? When did you first get an inkling about this pandemic? What do you remember about first knowing that something different was happening?
Yeah, well, I think some people, some of the listeners will know, and certainly you'll know I'm a bit of a Twitter addict. So I spend a little bit too much time on Twitter. And I remember very distinctly this on December 31st, New Year's Eve actually was the day, so I'm not overly pathetic, but New Year's Eve day, I remember reading this tweet from Helen Branswell, an old friend, saying, oh, look, there's these cases of unusual pneumonia in China, and this is giving me flashbacks to SARS. And that's the exact same thing it did for me, and I'm sure yourself. We remembered 15 years earlier what happened with SARS, and this looks so eerily similar. And within days, we knew that, in fact, it was a coronavirus. And that's when the alarm bells should have gone off. If people like myself, I'm not an expert on any of this stuff, I could see the danger. I think our officials should have known at that time as well.
Yes, and SARS was such a horrible outbreak here and around the world, but compared to SARS, this is very, very different, much more disruptive and devastating in so many ways. You talked about this a bit before, but as that was happening, when did you first start thinking about the elderly, our long-term care and our nursing homes? We both watched, as you say, the Premier of Ontario and others be absolutely shocked at what happened. But when did you know what was going to happen?
Yes, I started writing about the coronavirus in mid-January. So this echoes of SARS. I was writing columns about, boy, if this is another SARS, here's what we should have learned, right? So sort of rehashing the report from a decade and a half before. In early March, I actually wrote a column saying the most vulnerable people to a new virus are people in long-term care. So again, just echoing knowledge of others, putting it into newspaper form. And that was before there were cases announced in Canada, before there were deaths. So again, this was entirely predictable to even non-experts. And that to me is one of the big frustrations on this, that we kind of acted surprised when these outbreaks started, actually a few days after I published this column, coincidentally.
And not only, you have said that people should have acted, could have acted, should have acted. Not only was there not action in time, but in fact, looking back, I think there were actions that made matters worse in some cases.
Yeah, there were many actions that made things much worse. We acted very properly with our hospitals. So hospitals reacted to this really well. They fared really well during COVID because they acted early, but they made some big mistakes. We protected our hospitals so much that we kind of forgot about everyone else. There's a phenomenon in Canada, which you'll know, called ALC patients, so alternate level of care patients. It's kind of this Orwellian term we use for people who live in hospitals, who we don't have anywhere to send them. So in Canada, there's about 7,500, all older people, most of them with dementia in this situation. So they're living in hospitals, not a very good life, but waiting for a place in a care home. Immediately when the threat of coronavirus came, we actually moved those people in a panic into nursing homes. We made them vulnerable and many of them died. So that was one really bad decision. The other one was we provided a lot of PPE. It was rushed to hospitals, PPE, personal protective equipment for staff. We didn't do that for the care homes. They were left to their own devices. They didn't even have simple masks and gloves in the early days. And that's another reason this spread readily. And the final one is we have a long-standing policy of casualization of labor in these homes. So a lot of workers were moving between homes and they were perfect vectors. Yep. So employees, through no fault of their own, spread this at lightning speed. So again, we saw this explosion of cases in early March. And by April, as I mentioned, there were already thousands dead.
Yeah. I found, and I, like you, have talked to people whose stories really haunt me. And, but I found the first half of this book difficult to read, actually, rereading some of these stories. What stories have stuck with you of individuals or situations that you've read about, talked about, interviewed people about during this?
Yeah, like you, I think like any reporter on the COVID beat, where many of us are haunted by many of the stories we've covered. What I tried to do in the book, I actually deliberately tried to choose sort of middle of the road stories. I didn't choose the worst case horror stories. I tried to get ordinary people. So just stories of people, locked out of their homes, can't see their loved ones for months. That was a real, sort of collateral damage story. People whose loved ones had lived in homes, at home, had just recently gone into a nursing home, sort of the normal evolution of things. And then the COVID hit and they couldn't get them out again for all kinds of bureaucratic reasons. Just people who struggled with the costs. These are very costly things if you want to keep a person at home with home care. So people were forced, they didn't want their loved ones to be in a home, and they ended up there and they died, and they're just racked with guilt because they feel that they failed them. But it's not a fault of the people. It's really the fault of the system giving people no options and no ability to do what they want to do. So a lot of these stories are very haunting, and they stay with you.
You very controversially, I think, advised people, and you will know the date and will be able to tell me, but advised people, if they could, to take their loved ones out of care homes early on in the pandemic.
Yeah, I did. That was in early April, and I did get a lot of flack from people for saying that. Now, I make sure to always say, I said, if you can get your loved ones out of there. I've heard really touching stories from people saying they did take their loved ones out, and they're really glad because it got so much worse after that. But it was just another example of, I always stress this, I'm not any expert, and I could see the writing on the wall. So I was trying to drive home that message that we really have to understand how grave this is. And that was a way of doing it. And then I got a lot of angry mail from people who couldn't take their loved ones out. And I understand that. I've had parents in that situation who I know had to be in care, and I wouldn't have been able to take them out. But the intention was not to guilt them, to make them feel that they're failing. The intention was just to draw attention to just how serious the situation is, particularly for policymakers. And I think a column like that did ruffle some feathers in a good way.
Yeah, and that's your job, isn't it? I think, yeah. What could governments have done? I mean, we have talked about the things that were, but once we have this system in place, and I want to get to that because that's really what the book is about, is our whole system of caring for the elderly. But what could governments have done as this carnage was happening differently that might have reduced some of this?
Yeah, I think unfortunately, there are countries where there were no COVID cases, no COVID deaths in institutional care. I don't think that would have ever been a reality in Canada, just because our system was structured to create the perfect environment for the spread of illness. So I think we were doomed to a certain number of deaths, but I think it could have been attenuated quite a bit early on if we had done simple things. Stop workers from moving between homes. That's something British Columbia did early on, just a provincial decree. Everybody has to, the provincial health officer in BC, Bonnie Henry, literally, she has the power to do this under the law. She took over the staffing of the homes, and she said, beginning today, tomorrow morning, everybody's a full-time staff. They only work in one home. BC had tremendous results in the first wave. Unfortunately, got worse in the second wave, but that's just one example of stuff we knew we could have done. To this day, you can still work in multiple homes in Quebec and Ontario. And that, to me, boggles my mind. We know that that's a really effective thing. Getting PPE to homes would have saved lives, no question. I think informing the public. I think we did a terrible job of telling the public how bad it was. A lot of people would have taken their loved ones out with, they would have had a lot of trouble, but they would be alive. So I think there's a few things we could have done early on that would have made a big difference.
Yeah, you're right. There's a few things. I mean, I'm shocked too that people can still move from home to home. It was kind of changed, but not really, right? If you can. So yeah, there have been a lot of half measures that didn't do enough.
Yeah, it's kind of a lot of those rules are like French grammar. There's a rule, but there's so many exceptions that the rule is not that important.
So what does all of this, what we have experienced, and well, I mean, I guess we should get to the first wave of the pandemic was a horror. We saw the military going in Quebec and Ontario, and in Ontario, that report that, Premier Doug Ford stood up and was just gobsmacked by what he had read. And yet for years, anyone who's worked in homes has been telling us that. I mean, I personally found it was a bit frustrating to have the military come in to tell us what we've been told. But that was the first wave. The second wave was worse for the elderly in long-term care, right?
Yeah, and I don't think people always all realize that is really doubly shocking. That, yeah, it was horrible. We can make excuses for it's a new virus, we weren't ready, but we had no excuse for the second wave. And we knew a second wave was coming. Again, history tells us that this is how pandemics pan out. So yeah, it was really tragic that the second wave was worse. And one of the reasons is it's because it hit a larger part of the country, like Alberta, Manitoba, Saskatchewan, they virtually escaped the first wave. And they got a little bit too smug about it. And they were really hit hard in the second wave. So it's a reminder that you can never let your guard down. You have to learn lessons from tragedies. And if not, I don't know, if you don't learn from a tragedy, I don't know if you ever learn lessons.
Yeah. And now we have a third wave, but we have vaccinations. I mean, I think pretty much every resident of a long-term care and retirement home in this province has at least one vaccine, if not two by now. So that should change the picture. There might be other problems coming, but we still have this system of care for the elderly. So what has all of this revealed about our system, how we care for the elderly, what we do and what we don't do?
Yeah, I think it's been revealed a lot of really important things that, as you've said, we've known for a long time, but we've been forced to see them finally. So I think it's revealed that we have these public policies that are pretty fundamentally ageist. How could we allow ourselves to pay attention to hospitals and not long-term care homes when we know the most vulnerable in society live there? It's because we think of older people as disposable. I hear every day, well, it's just old people who died. It's not a big deal. I find that view really sickening personally, because these are not people who are, they were going to die anyhow. That's not true. They weren't going to die in the immediate, and they weren't going to die in this horrible way alone with their continence pads not changed. People died in really horrific circumstances early on. So I think there's no excuse for saying that. So I think the policies writ large are really horribly ageist. And it just reminded us, I think, that the system is not a system. It's kind of a mess of homes and inadequate home care, inadequate social housing, homes that are outdated, understaffed, poor infection control. It's kind of the perfect storm for a virus to spread, and we got the worst case scenario. So I think it's really shone a light on systemic failures that have been longstanding and never dealt with.
In fact, I have often wondered, there seems to be this almost shrug at the death toll from influenza and other respiratory ailments every year in long-term care. Is it possible that's been the warning system, that perhaps those are not necessary? Those aren't just what happens when you're that age? Is that to?
Yeah, I think we've been too accepting of that, oh, well, that's what, we still call pneumonia, the flu, the old man's friend, they died. It was a nice way to die. It was quick. And we still have that attitude. And there are, as you said, there are thousands of deaths each year. Now, this has been multiples of that, what happens during flu season, during COVID. But yeah, it's the same underlying philosophy that it doesn't matter, well, they're disposable.
It's also, I mean, people do die. Everybody dies at some point. It's the question of palliative care, and that's non-existent or not where it should be, not only, well, especially during the pandemic, but during other times. I interviewed a woman who's was told her father was going to die, and he was horribly in a great deal of pain from COVID in a long-term care home here. And a hospital happened to be in, and the doctor said, "Can we please send him to the hospital?" And she said, "Well, she believed she wasn't allowed to." And he said, "We can get it." Anyway, she thanked him so much. She said he had they could give him pain medication and care and things that he would not get in the long-term care home. Just, the basic sort of decent kind of death that people should have. So what's the situation with that at the best of times and the worst of times, as we have seen?
Well, the palliative situation is, again, another absurdity, right? Because as you said, yes, people are going to die there. I'm not denying that. They're there, you're there for the end of life. So to me, these should essentially be large palliative care homes, right? It should be about making your remaining days as comfortable as possible. And we have the opposite. Paradoxically, the hardest place to get palliative care in Canada is in a long-term care home. Only about 6% of residents ever have access. And that's before the pandemic. During the pandemic, it was almost zero. A lot of people don't know this, but there are policies we didn't bother transferring people to intensive care units in hospitals if they were over 80, because they had very small chances of recovering. Now that sounds, there's some logic to that, but there's no logic to it if you're not going to provide the comfort care, if you're not going to provide the palliation. So those policies, again, are just very ageist. Well, just let them die in misery. So we have to fix that. I think the philosophy has to be that. Now, people don't like to hear that. They don't like when I say, well, this should be a big palliative care home. But if you've ever visited, and I know you have, if you ever visited a hospice, these are very positive places. There you have control, you have your family with you, you have a decent environment. Everything's about what can we do for the weeks that you have left to make them more pleasant. And that's how I think we should treat our elders, especially those who are at end of life. It shouldn't be this dismissal and, let's hurry it along by getting you a virus. That's kind of been the attitude.
Yeah. You pull no punches in this book. I'm going to read you a quote that I noticed on Twitter that someone had put on a t-shirt, which is interesting. But elder care in this country is so disorganized and so poorly regulated, the staffing so inadequate, the infrastructure so outdated, the accountability so non-existent, and ageism so rampant that there seems to be no limit to what care homes can get away with, which sums up some of what you've been saying. But how did our care system for elders become what it is today?
Yeah, how did it become this system of neglect? I am a big fan of history, medical history and social policy history, because I think it helps explain a lot of the problems we have today are structural, and they came up through history. And the history of long-term care is actually fascinating in a gruesome way, in that it didn't come out of our healthcare system. It came out of the penal system, out of the penitentiary system. And it goes back several centuries to this notion of, the poor are not really deserving, so they have to work. We're not going to give anybody handouts. That's sort of the Elizabethan poor laws of the early 1600s. And that philosophy existed in our laws and in our policies well into the 1960s. That elders, if they couldn't be kept at home, if they couldn't afford to pay, well, they had to work for their keep. So we had workhouses. We imported those from the European model. You had to work for your food. If you didn't work, you could be put in solitary confinement. People wore uniforms in these homes.
Seriously? These are, I'm not familiar with this history.
Yeah, so in fact, that system existed until 1961. That's when the Nursing Home Act went into effect in Ontario. And now it wasn't widespread. It sort of, it petered out after the Second World War when we started having social programs, but there was a lot of lingering of this old system. In 1961, we became very progressive, and we moved to 4 bedrooms. There used to be 20 bedrooms in nursing homes before that. So you can imagine.
Oh my gosh, yeah, wow.
How much worse that was. There was an inspector of, they were called work homes at the time in the 1950s, and he wrote stories about elderly women being locked in the basement because they hadn't done their chores, not denied food for days.
Wow.
This is in Canada. We're not
Yeah.
talking about in the developing world. So this is the reality. The history has left a big scar on this sector. And the other part of it is the charitable part. So a lot of these homes were charitable, but it was the same thing. You know, you're not really deserving. We're doing this out of courtesy. We're going to give you the bare minimum, and we're going to expect you to pray in return, etc. And again, work for the parish. So all this is really ingrained in our way of thinking about welfare in general and social welfare for the elderly as well.
And Canadians tend to be very proud of our healthcare system, and I think you've argued that not with good reason, but should they be when it comes to elder care? Where does it fit into our health system, or does it at all, really?
Well, I think that's the problem, is it doesn't. So we have excellent, I think, you know, our health system has problems, but we have an excellent philosophy of care, at least pertaining to sickness care. So our hospital care, our physician care is provided to everyone without any barriers to payment. So that's a really good philosophy. But once you get out of that acute care, hospitals, doctors, you kind of fall off a cliff, right? It's kind of the Wild West. Some things are paid for. We pay for some home care, some drugs, a little bit of long-term care, but it's all over the map. So it's not really a system anymore. And that's, I think, doubly true with the institutional care, because there's all these layers of, there are retirement homes, there are nursing homes, there are lodges, for-profit, not-for-profit, municipal. There's a real mix of hundreds or 626 different care homes in Ontario, and they have all kinds of different shapes and sizes, administration. It's not a system, it's kind of a mess. And that allowed the virus to spread too. There was no organization in the sector.
I was actually shocked, and I shouldn't have been, but by some of the costs people pay for care, and then additional care because, or, you know, within institutions also the home care piece, but people.
Yeah, a lot of people do get a very nasty shock. We have this assumption, because we do love our Medicare system, we have this assumption it's going to take care of us, right? And it'll take care of us if we're in hospital. But once you're in this chronic illness, you're aging, you have some conditions, but you don't really have an acute problem. You don't need something that they can fix in the hospital. Then the bills start piling up. You have to start paying for your accommodation. You have to start paying for care. It's means tested, unlike the rest of the health system. So if you have money, you have to literally drain your resources, all your assets, until the government will help out. And people are shocked by this. As you mentioned, care, it ranges from about $1,200 a month to $15,000 a month, depending on where it is, what kind of home, etc. And the government does subsidize, but it'll only subsidize it if you're actually really poor, if you just don't have any assets anymore.
Yeah, and a couple of things I wanted to talk about. One is home care, which should be, what should home care be in your view versus what it is, I guess.
Yeah. Yeah, so I'll tell you what it is. What it is an adjunct to acute care. So it's a way of getting people out of hospitals more quickly and taking care of them a little cheaper. So if you get surgery, you used to stay in the hospital 2-3 days after a minor surgery. Now you often leave the same day, and you get 2 or 3 days of home care. And so it's this extension of the hospital. So everything in Canada, you know this very well, our system is very hospital centric. So that's what home care is, an extension. What some home care is, and very little, but what people really want, is support to stay at home for a long time. And we just don't provide that because we have all these arbitrary limits. In Ontario, you're not allowed more than 90 hours of home care in a month, so no more than 3 hours a day. And that's not adequate when people get to a certain amount of need. So then what do? They start paying out of pocket, or else they're forced by default to go into homes. And that's the unfortunate thing, is we underuse home care and we default to this much more expensive model, which makes no sense financially or ethically or whatever. The final thing I'll say about home care is it's a strange system in that it's the only service in Canada where there's just arbitrary limits. So you say a limit of 3 hours a day. We don't ever say to people, you have cancer, you need 12 hours of chemo. oh, but sorry, we only pay for 3 hours. You're going to have to find a way to pay for your other 9. People would be outraged by that, but they don't seem to be outraged when we do these arbitrary caps on home care for the elders.
Yeah. One of the points that you make in this, and I know this is something I have heard you say, that we are a country that loves to study things, and it is, I mean, it is quite shocking how many studies there have been about long-term care in particular. And there's an inquiry going on in Ontario right now, but your plea is that we've studied enough, that we know the answers. It's what is stopping those answers from being carried out? Why is this continued to be studied?
Yeah, I think, you have to do the study to a certain extent, but we've done it. We know all the problems and we know all the solutions. So to me, we have to start doing these inquiries differently. I think we have to assign sort of these blue ribbon panels, and we have to say to them, solve this particular problem. So take an example. I want you to tell me, I'm the Premier of Ontario. I want you to tell me how to solve the staffing problems in care homes. And here's $2 billion to do it. So I think that's how we have to do inquiries, is giving them a specific goal, commit upfront to implementing. Otherwise, it's just easy to do what we've always done. Every report comes out, we express shock and indignation. We implement a few, cherry pick a few easy things to do, all the low-hanging fruit. And the major systemic changes never happen. We just kind of move on. And we have to get out of that really pointless exercise. We have to commit up front to do something, or else there's no point in studying it.
And I mean, studies very much are a sort of a way of spending time to get it away from the government in question. Often is that, at least that seems to be the case to me. They, push it down the road a bit. So
yeah, I think governments know that unfortunately people have short attention spans, and you put an inquiry in place and it delays until we have another thing to worry about in the daily news, and we forget about it.
Yeah.
So I hope this time, we don't make that mistake again. But, I tend to think we're 16,000 dead. If that doesn't make us change things, I'm not sure anything ever will.
There's been an awful lot written about the people who devote their life to caring for the elderly, and those include the people professionally who do it, and plus the families who devote their lives to it. And you spend quite a bit of time in this book talking about both. And it's a mix of caregivers, nurses, and RPNs and RNs and PSWs, orderlies, I think they're known as in Quebec. But tell us a bit about PSWs and how they fit into this whole fractured system.
Yeah, so I think COVID has really shone a light on them. People who didn't know this group of workers, probably one of the biggest healthcare groups in the country. There's maybe 350,000 personal support workers, and they're really the hands and the feet and the eyes of people in care, right? They do everything for them. The toileting, the bathing, the feeding that people can't do, the PSWs are there to do it. So really essential work, a really exploited population. They're paid very little in many cases. We learned during COVID, some were getting as little as $13 an hour. So about the same as they would get working at McDonald's for caring, doing really intimate care for your grandmother. PSWs have a big turnover because this is not appealing work. But beyond the turnover, there's this really core group of lifers. People are really dedicated to do this work lovingly and do it for a long time despite all the abuse they get. So I wrote about a few of them in the book and how, they're really caring people who want to care, but they're just frustrated by the inability to do it. They just don't have enough hours, enough ability to care for people the way they'd like to. The other part of this puzzle is, what we talked about earlier. It's very casual work. So it's a lot of turnover. People don't see the same PSW twice. If you're having someone bathe you, you want it to be someone who knows your body, how you react, etc. So the best care comes with consistency. And we really have to put more value into that. And you do that by creating full-time jobs, by training people properly, by paying them a decent wage, etc. And the final thing I'll say about PSWs is they were literally people putting their lives at risk every day to care for people. A lot of them were infected with COVID. Many of a couple of dozen died. even though they tend to be younger, healthier people. They were really, really hard. And I won't even talk about the mental health impact on this. And we know that this workforce, they're invisible because who are they? Well, they're immigrants, they're refugees, mostly racialized women. So the people, again, another group that we easily forget in society. So I've often described COVID as this, what happened in our nursing homes is this intersection of ageism and racism and sexism, because what it is racialized women caring for older women, the most forgotten people in society, those two groups. And again, it helps explain what happened and why we had such the breadth of this tragedy.
One of the more shocking stories I wrote during this pandemic was of PSWs living in shelters. In Ottawa, one of the first outbreaks in a shelter began with a PSW who was living there because I don't know who it was, but she, I think, couldn't afford any housing. And one of the women in charge of inner city health said she said they couldn't take the bus because they were working in long-term care. They would get in full PPE and head out from the shelter in the morning to their jobs. And she said it was the most heartbreaking image of the pandemic that has never really left her, just this, these people going to this work. So yeah, it's a lot of heartbreak out there during this pandemic, I think, really.
Yeah, it was very a memorable story that you wrote, and it just sort of underscores that how we take people for granted that do really essential work.
Yeah. So the other countries do better than us, many countries. As you said, Canada, and you can correct me on this, I think Canada certainly performed among the lowest of industrialized nations when it performed, but we had the worst record of deaths in long-term care homes, I think, around the world. So it's not inevitable what our situation is at all. So which countries do better than us, and why is that?
Yeah, so during the pandemic, I'd be hard pressed to find a country that did worse. So we had the worst record by a country mile. About 80% of our deaths occurred in institutional care. In the US, which had terrible COVID, it was 40%, and that's a disaster. So it just gives you a sense of the proportion of our failure. Who does it well? I think the Nordic countries always come to mind. I write in the book about Denmark kind of being the gold standard for doing elder care. If you're talking about long-term care, specifically facilities, it's probably the Netherlands who do it really well. And what do? I think the thing they do that's most different from Canada is just a basic philosophy. So the philosophy is we keep our elders in the community, we value them, and we keep them in the community as long as it's humanly possible. So that's the guiding principle. Canada doesn't really have a guiding principle. It has a default mechanism that, I guess when you can't afford home care anymore, we stick you in an institution. That's not a principle. It's kind of a washing our hands. So if you have this sound principle, and then countries again like Denmark, the Netherlands, what they do is to give life to their principles is they invest a lot in home care. And when you do need institutional care, and I'm critical of it, but I stress that some people, a large number of people are going to need it. So then we have to make sure it's nice care. So if you go to Denmark, or if you go to Amsterdam, you can walk down the street, family home, nursing home, family home. You can't tell the difference. The homes actually look like homes. They don't look like prisons. In Canada, a lot of our care homes actually look like prisons. They have 200, 300 beds, 4 to a room. You eat at specific times. The way to deliver good care is to make it about the person. When do you want to eat? This is your home. You eat when you want, you get up when you want. If you want a bath on Tuesday, you get it on Tuesday, not on Monday at 6 a.m. because that's what the assignment says, right? So it's all about giving people agency about their lives. And that's, I think, the worst thing about care in Canada is we take away people's agency and their dignity.
I mean, there are some bright lights, right? In some homes. What are some examples of things that we're doing well, or some ideas that could be expanded?
Yeah, absolutely. And I think it's always important to underline that we do a lot of good care in Canada. And I think that's actually a positive thing, is we just have to take what we do well and scale it up. We have to stop scaling up our failures and start scaling up the things we do well. So I'll give you a couple of examples. One, there's butterfly care. So this is an approach of patient-centered care. York Region has gotten a lot of attention about doing this in a public home, so it doesn't cost any more than a lot of these nice different approaches are very expensive, but in York Region, it's publicly funded. And you get this butterfly care. So it means you live in a home-like facility, you get to pick your schedule, your food, etc. So very person-centered. Another example I write about in the book is Sunnybrook Veterans Center, located at Sunnybrook Hospital. And it's been around since the war years to take care of veterans. Now, it's not a nice looking facility. It looks really ugly from the outside, to be frank. It's huge, it's 475 beds, but it's broken down into smaller units. And the really important thing there is the philosophy of care. These are veterans, we respect them, and we're going to give them the best life that they have left. And, you know, the war was a long time ago. The average age there is 96. A lot of, you know, almost half the residents are over 100. But the idea is we are going to give you the best life possible for the years or months you have left. And it's all about my favorite anecdote about Sunnybrook in the book, just to give you an example of how they think. A story of a lot of the residents have dementia, and they have a beautiful garden because people with dementia like to wander. So there's a wandering path inside, another one outside. So as a resident outside, he was accompanied by a nurse, and he started pulling up the flowers in the garden. And the gardener got angry. He yelled at him, "You have to stop that." And the nurse said, no, this is his house. If he wants to pull up the flowers, he can pull up the flowers. That's how you think. And the gardener was, "Oh, I apologize." But to me, that's the kind of care we have to provide. We have to say to people, you do what's going to make you feel better for the rest of your life.
I want to ask a couple other things. We've got a lot of questions coming in, so I'll get to some of those. But you have a prescription in this book for what needs to happen. You probably talked about some of that, but maybe go over some of what should happen in elder care to change the situation we're in.
Yeah, so the prescription, again, nothing original in there. It's just taking these 150 reports with thousands of recommendations over the years and boiling them down to the 10 points that are repeated over and over again. So I start with the philosophy. First of all, you have to just have this belief that people belong, regardless of their age, regardless of their ability. They should be part of society. So once you have that, I think the other stuff, everything else is pretty technical. It's just putting our values into reality. And that's what, again, where countries that do care do that. They say, these are our values and we're going to do it. So what are the practical things you need to do? I think you have to start where the biggest problem exists, and that's staffing. So you have to make sure we have adequate care, whether it's in the home, whether it's in an institutional setting. You have to make sure there's enough hours for people to do the hands-on care that people need. So that's really essential. So it starts with standards. A minimum of 4 hours of care is what we should have. We don't have anywhere near that in Canada. We should have the proper mix. So we shouldn't have PSWs are important, but we need RNs, we need LPNs, we need physicians. A lot of the medical care in homes is unfortunately second rate. It's kind of retired doctors who are kind of coasting. They do what I call in the book medicine by fax. The nurse calls them in and tells them, can you write a prescription for this? And the doctor says, sure, and never sees the patient. So we have to do that better care overall, better personnel. The second one becomes the infrastructure, and that counts for infrastructure of home care as well. So have more organized home care agencies, then have better looking homes, move from this big facilities model to a more home-like facility. And then you just keep going from there. When you do those two biggies, you've solved a lot of problems. Then it becomes more issues of government structure. So in Ontario, you probably have 5 or 6 different ministries who have responsibility for elders for different parts of their lives. So no organization, lots of buck passing, nobody takes responsibility. So make elders important constituency and say, we're going to have a ministry for them and we're going to take care of everything, make sure they're taken care of throughout the continuum. So that kind of structural issue, and so on and so forth. And there's a number of other more technical points in there.
and your book is about elders and about elders care, the way we look at elders. Very much, I think the debate and probably a lot of what's get said about it, it focuses on long-term care and homes. I like the fact that you expand, it's more of a holistic look. But I am going to ask you a specific long-term care question, which is a question of private versus public. We know the NDP, both in Ontario and federally, are pushing for an end to privatize long-term care homes. They make up a lot of majority of homes in this province, I think. There's been some research done about how they fared versus not-for-profit homes. But what's your view on that question?
Yes, so this issue has been coming up a lot. So I answer it in two. So the first stage, I think, I say, do we need for-profit care homes? No, we don't. A lot of countries don't have them. That's fine. But the reality is we do have them. So the issue I think we have to figure out is how important is it to get rid of them? And to me, it's about number 25 on the priority list, right? So there's a lot of other things that have to be done regardless of the ownership. And the ownership issue, I think that's one we can afford to kick down the road. If we have good standards of care, we have better personnel, we have better food, a lot of this stuff will work itself out. And in fact, a lot of the for-profit operators will leave if we have those rules. That's part of it. So we can do this in different ways. My big worry is that we just embrace something, I think this is more of a dogmatic statement, but let's get rid of for-profit. And then we don't do the other stuff that we have to do. The reality is if we had no for-profit homes tomorrow, would care be better? In the existing system? No, it wouldn't. It would be exactly the same. And we have to ask ourselves, why are they there in their first place? They're there because governments refuse to invest adequately in infrastructure. So we depend on them to be builders, to have mortgages, and then we buy services from them. So resolve that problem. If government wants to start building homes, fine, then they're less needed. So I don't like these simplistic solutions to complex problems. The final thing I'll say about private is there's a lot of different kinds of for-profit homes. There's a lot of family-owned institutions that are for-profit institutions, and they're great. A lot of them in rural communities, they're well-known, they're wonderful facilities. There's some chains. The chains some of them have really good homes, less good homes. And then there are the people I think we really have to get rid of, who are essentially just slum landlords. They're people who are there to make money buying and selling the land on which the homes are situated, people who don't care about the people one iota who live there. They're just widgets to collect money from. And they're a very small percentage. An example of them is a lot of people have heard of Heron, the horrible situation in Montreal. That's an example of people who should not be in this business. They know nothing about care. They're real estate people. Those are the ones we have to get rid of immediately. But that's a very tiny percentage of the for-profit homes. So pick our targets, pick our priorities, and do it that way would be my lengthy response to that question.
Yeah, okay, that is a question, yeah. We have a lot of questions, so I'm going to read some of them and we'll get through what we can. So this is from an anonymous attendee. Thank you, Andre. I am angry, sad, and frustrated too by the response of governments of older adults living in long-term care. Can you talk about the exclusion of family caregivers from homes, and how it contributed in the early days and how it contributed to the outbreaks? I still think it's criminal that we did not provide direction to ensure families could be there for family members. Thank you.
Yeah, I think it's an example of a well-intentioned policy that went horribly wrong. So I think we went really overboard by locking out caregivers. I think it made us realize just how important they are. You know, caregivers, family members provide a lot of care even when people are in homes. They're there. You know, my mom, when my father was in a care home, was there 3 times a day feeding him his meals. She was his sole source of companionship. So families are really, really important. And by locking them out, we really harmed residents really badly, especially people with dementia. They just didn't understand why are my loved ones, why have they stopped coming? Do they not like me anymore? Do they hate me? These things were very, very devastating. I had a family member, my father-in-law, who was in a home. He was in very good health. He was living in a retirement home. He went from pre-pandemic, playing tennis 3 times a week, bridge every day, going to church every morning, going to the library to take out books, to being locked down for months and months. And he died. He died, I think, of loneliness, to be honest. He just was deconditioned. He was devastated. He was depressed. And those numbers are really, the COVID deaths are easy to count. Those other collateral damage, they're very large numbers, but they're difficult to count. So was it a mistake? Yes. We should have taught people how to use PPE. We should have made every effort to allow them to do essential care. And we didn't do that. And again, what's the basis of this? It's ageism. It's just, we can just lock these people away. We would never do that with any other. We had lockdowns in mainstream society, but they were nothing compared to what happened in homes, where you literally, there are places where you couldn't leave your room for weeks on end. You couldn't leave the building for months, for up to a year. That happened to no one else in society.
And I have a next question, and it is more along those lines, and it's kind of a live question, because now we have long-term care and retirement homes where everybody is vaccinated and they're still in lockdown because there are outbreaks when a staff member gets infected. So I think, so this question is from another anonymous attendee who says, why hasn't there been more coverage on staff immunization rates in long-term care and retirement homes? Every time a facility has a non-immunized staff member test positive, the whole place is locked down, and very frail elderly people are confined to their suites with no activities or visitors. Many private facilities refuse to release staff immunization rates.
Yeah, I know this is a big frustration of families. It is frustrating that a lot of staff are not vaccinated. I think we have to do a better job of convincing them. If you make vaccination mandatory, I'm not sure it'll solve the problem. I think you'll just lose workers. As I said, these jobs we have massive shortages. We have an inability to train people, et cetera. So that, I think the consequence of that would be probably worse than what's happening now. So I think it's, why are staff members not getting vaccinated? I think a lot of it has to do with just poor education on our part. It's not doing public health messaging in these communities. A lot, as I said, are refugee immigrant communities. We have to communicate better with them in their language. We have to have peer-to-peer discussions about this. A lot of people come from countries where there's ingrained disrespect or fear of the health system. So it's natural that people have these feelings. There are ways to resolve this. A lot of places have done it well. Vaccination numbers shoot up if you do this properly. And I think that's the way. Just bringing the hammer down is not going to work, unfortunately. Okay. So I understand the frustration, but I think we have to understand too the basis of this, why it's happening.
We have a question. Oh, Mary, I'm going to mispronounce your last name, but she was quoted in your book, so you can tell me how to pronounce it. Mary Wong.
Yeah, Mary Wong. Yep.
Yeah. Mary says, I see some very good models from around the world, and I'm going to mispronounce this too. And now I've lost your question. Hoogwijk Dutch Alzheimer Village, Swedish multi-generational housing, Danish co-housing, a Dutch nurses cooperative, and more. Why do Ontario and Canada, why are they so reluctant to look and adapt at some good models like this?
Yeah, I think it's a very good question. Why do we not embrace innovation? We talk a good game about innovation, but we don't do it. So some of the examples she gave, Dementia Village is a really good one, where you put people in communities with common interests. So you take people who were farmers their whole lives, they now have dementia, you put them in a home on a farm and you take care of them there because it's more home-like for them. So
and where is that one? That's in
the Netherlands. That's
yeah.
an example of a dementia village. We have one in British Columbia, but it's very expensive, unfortunately. So we have some of these models in Canada, but unfortunately many are private. The housing aspect, I think, is one we didn't talk about a lot, but it's really important. If we invest in social housing and supportive housing, you can keep people in the community much longer. So I wrote in the book about a facility, Toronto Public Housing, where the caregivers live on site. So you just bring the care to the people instead of forcing them into a home or having care agencies come in and out. They live on site and they take care of people. So that model is very popular across Europe as well, much more efficient. So why don't we do more of this? There's a 10-year wait list for that, those homes in Toronto. There's a desire for them. I don't really have an answer to why do we not do it? We're kind of just set in our ways.
Another question from A. Marie. I am acting as primary caregiver for my grandmother. She has many health concerns and now dementia. She got her first dose of the vaccine, but we still have concerns as a family when it comes to next steps of her long-term care plan in this climate. What do you say to those who are looking at long-term care plans for their loved ones where the home is no longer sufficient or sustainable for the family and caregivers? Sorry, I'm not sure.
Yeah, that's a tough one. I think the good thing is to have a care plan. A lot of people don't think it through that far, so that's a great starting point. The part about the vaccinations, we know a lot of elders are vaccinated, and that's great, but in most places, they only have one dose so far. The biggest risk is, and we know the vaccines are not going to prevent 100% of cases, especially in older people with weaker immune systems. So we still have to protect them. And the best protection for everyone is minimizing the amount of spread in the community. So we really have to get, bring the hammer down and get the cases down in the general public. That's the single most important thing we can do to protect elders. That's what puts them at the greatest risk. The part about, is the home appropriate anymore? That's something that many people with dementia struggle with. I have a story in the book about someone who they'd moved to 5 different homes in 5 years. A lot of homes just can't cope with the high needs patients, and that's a big problem in our system as well.
I'm going to read this one. Angela asks, have you had feedback from federal or provincial government leaders, healthcare, that they have read in your book? Sorry, I'm struggling with this. I mean, we'll start. Have you had the feedback from politicians or anyone in government who's read this book and has comments or response to it?
Yeah, no direct on the record feedback, but a little bit of a sense that, yes, this is top of mind. I think I've learned something over the years. I used to be much more critical of politicians. I think I've learned that essentially they lead from behind. So they'll do essentially what they think the public will tolerate and what will get them reelected. So I think what's really important at this point is people just don't let go of this issue, that they just hammer away, they demand. I think ultimately we all have to demand that everyone get the care that we want, right? So we always all want to be treated with dignity and respect and have agency over our lives. And that's the system we have to build. I said it earlier, I think it's a key point that we have to give life to our values. And that's what it's all about. One of the most uplifting things for me in promoting the book has been not hearing from government officials, but hearing from lots of young people. Lots of young people are just really, sickened by how they saw their grandmother or great-grandmother treated. And I think if you get that, that solidarity across age groups, if young people start saying, hey, this matters to me too, I think that's when we can change, and we can change really quickly, because as I said, we know all the solutions, a lot of them are in place, and scaling up is easy to do. So it does give me hope that we can, if we set our minds to it, we can make a lot of change in very short order.
And certainly, I mean, I've noted this pandemic has created real activism out of necessity among family members. It seems there might be some real political pressure there for change. Is that what you're seeing as well?
Yeah, absolutely. It's been really interesting to see who's come forward to advocate for long-term care. A lot of people, like I see dentists and scientists and gas station owners, sort of people who are all sort of focused on this issue because it's touched them personally. And again, that's how change comes about. If it's not just a niche issue, if it's a big across societal issue, that's when politicians really start paying attention.
Yeah, I'm going to read one more question. We're coming down to the end of our time. This is from Facebook. When we look to the Nordic countries for best practices, are they publicly funded, or do they have nonprofit or private models that work? I feel like our privatization of LTC-based environments are environments where corporations are beholden to shareholders. So the question is, what do you know about funding for some of those models?
Yeah, so Nordic countries generally are different from us in that they have much broader coverage. So I often use the analogy of a basket. So we have this Medicare basket of services, and we cover a couple of things, doctors and hospitals very narrowly, but very deep, 100%. And then everything else we cover scattered. The Nordic countries, European countries have a much broader basket. So they cover a lot of things publicly, dental care, home care, long-term care, but they expect everybody to top it up. So depending on the country, there's various means tests. So countries like, take Norway, which has really excellent long-term care. You'll be in a state-owned facility. It'll be lovely. The law says you have to have access to the outdoors, that you have a single room, etc. So lots of good rules. But if you have a high income, you'll pay a lot of money. So they believe in taxation based on ability to pay. So there is a private component to payment that is very different from here. In Canada, it's very haphazard. It's not regulated the way it is there.
I think we are pretty much out of time. I was very happy to hear you express some optimism there. That was to be my last question. How optimistic are you right now in history about things?
Yeah, I think maybe it's a bit unjournalistic. We tend to be cynical people in the media, but I am coming out of this hopeful because I do think we really know all the solutions. This is affordable. We didn't talk about the money question. It's often said, oh, well, this is great, but it's too costly. That's not true. It's not too costly to start off with. We've spent $500 billion on COVID relief. If we spend another 3 or 4 on elder care, it's really petty cash, to be honest, in the grand scheme of things, and it'll have a lasting impact. So I think ultimately it's about getting the care that all of us want, and that how can that not be affordable or desirable?
Good. That is a very good note to end on. I've really enjoyed this, Andre. I think I could ask you many, many more questions, and I know people who are watching this also could. So thanks so much for your time. I've enjoyed this and would encourage people to read your book. It's been great.
Thank you. Thank you for taking the time, and to the Ottawa Library and to the Writers' Fest for this very kind invitation.